Patients with locally advanced rectal cancer typically get treated with chemotherapy, radiation, and surgery. And although we do really well in terms of cure, there's a lot of toxicity associated, especially with radiation and surgery. And then there's a subset of these patients that are mismatch repair deficient. It's about 5 to 10% of them. And we treat them typically, standard of care is the same approach, but we actually noted that they don't respond as well to chemotherapy. In fact, up to nearly 30% of them actually progress through chemotherapy, which we really don't see in the mismatch repair proficient group. So our idea was to see if we could replace the chemotherapy with PD-1 blockade. And the reason we thought about PD-1 blockade or checkpoint blockade in this population is that it works really well in the metastatic setting. So in metastatic disease, patients with mismatch repair deficient colorectal cancer respond very well to immunotherapy. They have durable responses, and the complete responses are about 10%. So given the fact that the patients progressed on the chemotherapy and then we'd have to do radiation and surgery, which were curative but quite toxic, we thought, could we replace chemotherapy with immunotherapy and then design the study in such a way that if the patients responded very well to immunotherapy alone, so to PD-1 blockade alone, after 6 months of therapy, we would evaluate them. And if there was no tumor remaining, they could undergo non-operative management or observation, as opposed to getting radiation and surgery. If they had some residual disease, then they would get standard of care radiation and surgery. So the idea kind of was, how well can we do with PD-1 blockade alone in this patient population? Can we go all the way and see these complete responses to PD-1 blockade alone? And if not, then can we do just radiation with the addition of PD-1 blockade, or do we need to do the full trimodality therapy and include surgery? So we were very thrilled to see that all of our patients, 100% of them, had complete disappearance of tumor with PD-1 blockade with dostarlimab alone. So no one has required radiation or surgery to date. So this is really remarkable because it's 14 consecutive patients. So every single patient that's been treated, the tumor has completely disappeared with just immunotherapy.
That's amazing. What's next?
It's very exciting. We're still actively accruing on this study. Given these robust responses, we are planning a larger expansion trial. And hopefully this is continued and this will be the new treatment for mismatch repair deficient locally advanced disease. And our thinking is, well, could we apply the same approach to other early stage tumors that are mismatch repair deficient, where definitive therapy typically involves a combination of chemotherapy, radiation, and surgery? And could we achieve these same types of responses and could potentially spare them radiation or surgery or both? Just point out that many of these patients are very young. Many of them have Lynch syndrome, so they're diagnosed in their early 20s or 30s. And so being able to spare them radiation and surgery is huge, has significant implications because radiation and surgery cause bowel and bladder dysfunction, they cause sexual dysfunction, and importantly for this very young population, they cause infertility, especially in women. And so now we're able to treat them just with immunotherapy alone. They have preserved organ function, they have preserved sexual function, and preserved fertility, which is hugely impactful.